You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. I want to thank you all so much for joining us on this episode. Today we'll be discussing chronic lymphocytic leukemia, including signs and symptoms, updates on approved therapies and emerging treatments, clinical trial insights, strategies for managing complications, and survivorship, as well as practical approaches to supporting patients. And we're going to do all of that in about 30 minutes. So there's a lot to talk about. We're delighted to be joined by Dr. Brad Call, who is a professor of medicine at the Washington University School of Medicine and director of the lymphoma program at the Siteman Cancer Center in St. Louis. Brad, thanks for joining us.
Thanks for having me.
I want to start out first just by asking you how common or uncommon is CLL, both in terms of your practice as a subspecialist, but also more broadly.
CLL is the most common leukemia in adults. There's about 20,000 new cases each year diagnosed in the U.S., and people with CLL tend to live a very long time with their disease. So there are lots of patients walking around the United States with CLL, probably 150,000 or more. It's definitely a disease of older age. The average age at diagnosis is around 70. And for reasons we don't understand, it's more common in men than it is in women.
The number of people living with the disease is quite interesting because I know my friends in internal medicine are seeing some of these patients and less commonly are seeing the oncologist.
Right.
To me, what's always been sort of fascinating, I want to see how you handle this, but a lot of those patients, probably reflected by what you were saying, we don't do anything for. So you have that first meeting with a patient where you make a diagnosis. I'd love to hear your experience of consultation.
Probably the majority of new patients that I see with CLL, their disease was found incidentally. They were getting blood work for some other reason, and they were found to have this elevated white blood cell count. And so when we're seeing a patient for the first time, really what we're trying to do is determine how advanced the disease is for that patient, because many patients with CLL don't require therapy at the time of diagnosis, and some patients never require therapy in their lifetime. And so figuring out really what their disease burden is a high priority with that first visit. So we're interested to see what their blood counts look like. How high is the lymphocyte count? Do we have old blood counts in the system on them so we can see? Maybe we can look back and see this patient's had CLL for 3 years. It just was never noticed. And you can see they've been walking around for 3 years with it, and their lymphocyte count has barely budged, which is a great sign. We're particularly interested in their hemoglobin level and in their platelet count. Those are really the things that drive treatment for many patients. Is the disease accumulating so much in the marrow that they're getting marrow failure, leading to anemia or thrombocytopenia? So that can be an indication to treat. Obviously, we're examining them for lymphadenopathy and for splenomegaly. Some patients come in because they noticed a lymph node. Some patients come in with symptoms. Not a lot, but some. And the symptoms could be easy bruising, easy bleeding, could be profound fatigue, could be recurrent infections, could be pain from a big spleen or pain from a big lymph node. And obviously, if a patient has symptoms from their disease, then, it's time to treat. But if the patient has good blood counts and is asymptomatic, we're going to recommend an initial strategy of just observation or watch and wait, as it's termed. And that requires a conversation because it's very counterintuitive for patients and their family.
It is.
To tell them, hey, you've got a blood cancer. We have really good treatments for your blood cancer. By the way, we don't think we should use any of those treatments at this time.
Right.
And people struggle with that. I get a lot of patients who come see me at an academic center. They were already seen in the community by a community oncologist who recommended just a watch and wait strategy, and they just weren't comfortable with it. So they come to see me, and then I just reinforce that, assuming
Yeah.
that recommendation was appropriate. The way I'll often explain it to patients, and this usually works, there are some patients who just never get comfortable with the watch and wait idea. They just can't get there. But I'll explain to them how studies have been done in the older days with chemotherapy, but now even in the newer days with oral targeted agents, where you take 500 patients just like you, and half of them start on treatment right away, and the other half we start on observation. And then we follow the patients over time. And the patients on observation will start their treatment on a case-by-case basis when they meet our traditional criteria for initiation of treatment. And then if you look down the road, 5 years later and 10 years later, the proportion of patients alive in each group is identical.
Yeah.
So the early treatment for these people with no symptoms and low disease burden didn't really benefit them in a meaningful way. And when I explain it like that, I can usually get people more comfortable with the idea, but it takes a conversation.
I have to say I'm smiling as I'm listening to it because I find it's actually one of the most interesting conversations, as many are. We'll talk about it in a few minutes, but all the newer treatments and all the advances in understanding the biology. But I want to focus on that issue of today in 2026, for example. Has that equation changed in terms of upfront treatment versus watch and wait?
It really has not changed. Obviously, the older data is all with chemotherapy or even immunochemotherapy, but the German CLL study group has done studies now of immediate ibrutinib therapy versus watch and wait. And we now have 3 and 5 years of follow-up, and we're seeing no difference in survival. The U.S. cooperative groups are doing a study of early intervention of venetoclax obinutuzumab versus watch and wait in people who have biologically high-risk disease. We don't have any results from that study yet. But as of today in 2026, the recommendation, if the patient does not meet clinical criteria for treatment, then you should start out on a strategy of observation, even if they have high-risk biology.
Excellent. Thank you. That's something I've been wondering about. I want to ask you, some of these patients, I think to myself, is this CLL, very early stage, or is this an MLUS? So if you would say a little bit about MLUS and how do you distinguish the two?
Yeah. My own opinion is this monoclonal B lymphocytosis. I think it's kind of an unfortunate designation that only confuses people.
Okay.
I'll explain what it is, and then I'll explain why I don't love it. If someone has clonal circulating lymphocytes less than 5,000, it's considered monoclonal B-cell lymphocytosis, and they don't really meet the criteria for being called chronic lymphocytic leukemia. The disease already has 2 names, CLL/SLL, because some patients come in with the lymphoma version of the disease, and then it's called SLL, small lymphocytic lymphoma. So do we really need a third name at this MBL for one disease? To me, if someone has monoclonal B-cell lymphocytosis, but it's under 5,000, they just have CLL at a very, very low level.
Yeah,
I can explain that to a patient very easily. It's harder for me to explain to them that their disease has a different name, because what happens then when I see them 3 months later and their lymphocyte count that was 4,000 is now 5,300.
Right.
And they're like, oh, you said 3 months ago I don't have CLL, and today you're saying I do have CLL. Oh, this is horrible. And then what happens when I see them 3 months after that, and the lymphocyte count is 4,800. And they're like, oh, I'm so happy. My cancer has gone away spontaneously. I mean, it creates all these misunderstandings of the disease. So my own preference would be just to call it all CLL and just have us, the doctor, explain it to a patient. But it's at a super low level. And so I'm going to a meeting in March with clinicians and pathologists from all over the world, where we update the WHO classification on hematopoietic malignancies and come up
Hmm.
with all the nomenclature.
Yes.
And I'm going to make a motion to abolish this monoclonal B-cell
Ah.
lymphocytosis. I'll probably get shot down and it won't go anywhere. But I don't find it to be all that useful concept. They have clonal B cells that's CLL. It's just at a very low level. That's how I think of the monoclonal B-cell lymphocytosis.
So, by the way, I want to ask you the way I have been describing CLL to patients, and I want to see if this is accurate, is as a disease of accumulation rather than proliferation. Is that a reasonable description? How do you describe it?
Yeah, I think that's a very good way to describe it. And I usually do the same. These cells have sort of a don't die signal in them.
Yeah.
And that's
Yeah.
why they're accumulating rather than proliferating rapidly, like we think of most cancers. And yes, I do use that exact terminology when I explain it to patients.
What I'd love to learn, and I think colleagues as well, I mean, there are a number of risk factors that we're taught to pay attention to. So we'll talk about TP53. Could you pick some of the risk factors and explain them in a fashion where maybe they make a little more sense why that would be a risk factor?
I think the most important ones to get would be a CLL fish panel. And I like to get that at diagnosis just to see if we have any high risk biology. Usually the CLL fish panel will test for 17p deletion, 11q deletion, trisomy 12, 13q deletions. It'll look for those things. And a lot of these panels will also have the mantle cell translocation in it, so you can rule that out. It'll look for the 11-14 translocation at the same time. Historically, 11q and 17p were associated with worse prognosis. In the era of oral targeted agents, how adverse these things are has changed. And to be honest, 11q is probably not even a high risk feature anymore if you're using novel targeted agents. I think 17p is still a high risk feature, even in the modern era. And it does affect my thinking on treatment to a degree. I'm sure we'll talk about how to select treatment for patients in this session. So I like to get a CLL fish panel. Suppose your patient doesn't need treatment and you're observing them. Fast forward 3-4 years later, and now they meet some clinical criteria for treatment. I like to repeat the CLL fish panel before I initiate treatment because that can change over time. The other thing that I like to get at diagnosis is the IGHV mutational status. That tells you where the cell was in maturation when it turned into a CLL cell. And so if the IGHV locus is mutated, that means the cell had gotten through the germinal center of a lymph node, and that's associated with a more favorable outcome in general. And it can have some influence on your treatment decisions. If they're IGHV unmutated, slightly less favorable prognosis, and you might want to incorporate these things into your decision making. Notice I said might because there's not absolutes here, but when we get into treatment details, I can describe how certain treatments people might choose have differing outcomes depending on if you're IGHV mutated or unmutated.
You just gave me a better understanding of IGHV and prognosis. Why 17p? What is there about that arm? Why 11q for that matter?
You mean, why does it make the disease worse biologically?
Yeah. Is there a reason, or maybe it's just an observation?
I don't think I understand the biological reason of 11q, or if I did know it, it's not coming to my head at the moment. But again, that's not such an adverse prognostic factor nowadays with novel targeted agents. It seems like people who have P53 aberrancy, whether it's mutational testing, which reminds me, there's one other thing that people should get. If you have P53 aberrancy, whether it's due to mutation or deletion in 17p, that really predicts for poor responsiveness to DNA damaging agents.
Mm-hmm.
So back in the day when all we had was chemo, that was a big deal to be 17p deleted or P53 mutated. Now with targeted agents, they work much better in these P53 aberrant cases. It still has a slight adverse prognostic risk, but not nearly as bad as it was back in the day when all we had was chemo. But I think
Yes.
having P53 aberrancy just somehow makes the cells more resistant to cell death by DNA damaging agents.
By the way, it's very similar in some ways to HER2. Years ago, HER2/neu was very bad prognostic indicator. And now, honestly, it's obviously been a game changer many years ago that we can target that. All right, so let me ask you about the opposite scenario. You have a patient, because I have someone like this, who lymphocyte count maybe 6,000. It's been stable, no other clinical findings, but he's got TP53, and he's really a very smart man, really has wanted to follow that. So I do check, and slowly the amount of TP53 mutated cells is going up, but not a single change clinically. How do you integrate the biologics into the clinical picture in your practice?
Right. Yeah. If I had a patient who wants to track it from time to time, I have no problem with that. I would emphasize that we're still most interested in the clinical course in terms of when we're going to initiate treatment. But if you do see the variant allele frequency, the VAF of the P53 clone increasing over time, that suggests that that clone is starting to predominate and could become a problem. So patients want to know how their disease is advancing. I think that's fair. So I have no problem checking that serially. Having said that, I would still use the traditional clinical criteria for when to initiate treatment. Because you can have P53 mutant patients or 17p deleted patients with CLL who do go 5 years without needing treatment, 10 years without needing treatment. I have a patient from my prior practice. He sends me a note every year around Christmas. Hey, Dr. Call, I'm now 20 years into watch and wait. He's more than 20 years now. And we found a 17p in him at diagnosis in like 2004. So having that bad biology doesn't automatically mean they're going to have an aggressive clinical course.
You know, you have patients you follow for years, stable, and then all of a sudden the white count goes up and they develop a hemolytic anemia. I've seen this twice. Any idea what changes? What's your theory on that all of a sudden the disease is clinically active?
Yeah, I'm assuming, that there's just clonal evolution occurring, new mutations developing, new clone, a bit of a growth advantage. So you know how we said it's a disease of cellular accumulation, but now maybe you've got a clone that's accumulating and proliferating because of a new mutation that the cells have picked up. So I'm just assuming it's clonal evolution when that happens.
So ASH was recently.
Yeah.
And it sounds like things haven't changed, but what are your criteria for treating?
Certainly, if I see the hemoglobin dropping below 11, I think it's reasonable to start treatment. If I see the platelets dropping below 100, I think it's reasonable. Notice I'm saying it's reasonable. I've got a few patients who platelets chronically run between 80 and 100, but they feel perfect. And so every time I see them, I'm like, well, you do meet the criteria. They're like, yeah, I feel too good. Let's not do it. I say, okay, see you down, see you in 3 months or see you in 6 months or whatever.
Yeah.
So these just means it's reasonable to start treatment. It doesn't mean you have to start treatment.
Got it.
I think if you have autoimmune complications, poorly responsive to steroids or steroids rituximab, I would go ahead and initiate treatment. If you're starting to get very bulky lymphadenopathy in the 5-10 centimeter range, I'll think about starting treatment. If the spleen is getting to be problematic, but it's well below the costal margin, maybe they're starting to feel it a little bit, I'll start treatment. What's a little tricky is what to do if it's just lymphocyte count going up. So you see these patients and their blood counts are good and they feel pretty good, and their white count's 120,000. Okay, not going to treat yet because you don't meet any other criteria. Then I see them 3 months later. Now it's 150,000. Hemoglobin's okay. Platelets are okay. They feel okay. See in 3 months. Now it's 180,000. You know what I mean? Like, what?
Yes.
So, the guidelines are not to start treatment in those patients. Like the absolute lymphocyte count alone is not enough. So we try to resist starting treatment, but eventually you'll start to see something else happening, some anemia creeping in or some thrombocytopenia creeping in. They do say that if the lymphocytes double in less than 6 months, that you could consider starting treatment, or if they increase by more than 50% in a 2-month period. So there are some trajectories of lymphocytes that lead you to start. I'd say the trickiest scenario, and I'm sure you have faced this too, is the CLL patient whose disease burden is modest, but they don't meet any criteria for initiation of treatment, but they just say they're fatigued.
Yes.
So tired, doctor. And that one is really tricky. That's probably the hardest scenario. And I try really hard to see if there might be other reasons for the fatigue. Are there confounders? Maybe they've got sleep apnea that's poorly managed or some other reason.
Right.
Because I'd hate to start them on CLL treatment when they don't need CLL treatment. So a lot of times we'll try to look for other reasons, other causes. But say you're not finding anything, occasionally then I'll just do the experiment where if I have a patient who's just like, I can't live like this fatigue is horrific, and yet they don't meet criteria, all right, I'll say, okay, let's do a 2-3 month experiment, and I'll put them on a BTK inhibitor just to see what happens. I don't love doing that, but occasionally I feel like I'm just forced. Because what if it is the CLL that's dragging them down?
Yes.
I don't want to make them live like that because they don't meet some criteria. And so sometimes I do that, and the patients come in and they say, wow, what a difference. I feel so much better. That's when I love it when the caregiver comes in too, so I can get corroboration.
Yes.
Sometimes I'll have a caregiver say, you look the same to me. Or I'll have a caregiver say, oh yeah, big difference. We're doing way more things in the evening. We're doing stuff on the weekends. Couldn't do any of that a few months ago. Starting this pill has been a big difference maker. So it really helps to get a second person that's objective. And sometimes you start the medicine and they come in and they say, didn't do a thing. And I'm like, okay, experiment's over. We're going to keep looking for other reasons for your fatigue.
Yeah.
I will occasionally do that when I'm stuck.
Very interesting. Thank you.
Yeah.
All right. So let's focus in on that was one scenario, starting someone who has symptoms with a BTK inhibitor. How about other scenarios? Again, how do you make decisions on, because it feels like there's a lot of choices now. So how do you parse that out?
To me, there are 4 main choices, and you can kind of break it down into like a branching tree. The first thing I'm trying to think of, okay, what's going to be most appropriate for this patient? Indefinite BTK inhibitor or some time-limited option. If we think it's going to be indefinite BTK for this patient, then you're deciding between acalabrutinib and zanubrutinib. It's kind of a toss-up. They both work wonderfully. So who are the best people for indefinite BTK inhibitors? That's what I'll choose if they're 17p deleted or p53 mutated. The data looks best for indefinite therapy in that higher risk biologic subgroup. What if the patient's quite elderly, frail? I like the convenience of just the BTK inhibitor. There's not a lot of trips back and forth to the doctor. There's not a ton of monitoring that's required. It's generally well tolerated. So if my patient's maybe 80 years old or lives far away from clinic, and just the back and forth of all the monitoring that goes into the time-limited options isn't convenient, I'll choose a BTK inhibitor for that patient. On the other hand, my patient is younger. Maybe they're 60 or even 70. Putting them on a forever pill isn't as appealing to me. So I will encourage them to do one of the time-limited options. And the 2 time-limited options are venetoclax obinutuzumab, which has been around for over 5 years now, and it's well established. And then we have this new option of a pill-pill combination, venetoclax acalabrutinib, based on the Amplify study that was published last year. That regimen, venetoclax acalabrutinib, is not yet FDA approved, but it is in the NCCN guidelines, so you can get it paid for by insurance in most instances. And so that's a whole nother conversation, ven-obin versus ven-acal. And I just try to talk through the patient's pros and cons. If they're doing obinutuzumab, they got to come in for the infusions, a little bit of a hassle factor there. If they're doing the ven-acal, it's 2 pills. But when we start the acalabrutinib in month 3, we got to do the ramp up and a little bit of tumor lysis monitoring. So there's a little bit of a hassle factor involved, and we just kind of talk it through. I think this is when the IGHV mutated, unmutated thing can, I think, help sort this out. The ven-obin combination looks really good in the IGHV mutated patients, and it works less well in the unmutated patients. So if you do Ven/Obin, which is like 12 months, time-limited therapy, if they're mutated at 5 years, IGHV mutated at 5 years, they got a 75% chance of still being in their first remission.
Wow.
If they're unmutated, it's more like 50-50. So it still works well, and it's not a bad choice. It just doesn't work as well. And this pill-pill combination of venetoclax ACAL, we don't have 5 years of follow-up yet, but the early data in the IGHV unmutated patients is looking promising. And then there was this German study shown at ASH, the CLL17 study. With 3 years of follow-up, it looks like the pill-pill combination might work somewhat better than Ven/Obin in these IGHV unmutated patients. So
Got it.
I might start differentiating along these lines. I don't think the story is fully mature here, so I don't want to sound too definitive, but that's how the early data seems to be sorting itself out for me.
Wow. Now, by the way, I think there's a fourth. We talked about BTKs. We talked about pill, time limited. Was there a fourth?
Well, the ACAL versus Xanu. So I viewed indefinite BTK as two options. I will say one thing about, technically there are other options. You can add obinutuzumab, the anti-CD20 monoclonal antibody, to acalabrutinib. It is approved. You can add obinutuzumab to the pill-pill combo. So it can be venetoclax, acalabrutinib, obinutuzumab. So of those 4 combos that I mentioned, 2 of them you can add obinutuzumab according to the package inserts. I don't like doing that. I feel like it adds in toxicity that does not pay off. When you really look at those data sets, whatever improvement you get in progression-free survival is offset by infection toxicity, and the overall survival is no better and sometimes even worse. So I'm not a fan right now of adding obinutuzumab to those 4 sort of main options that I mentioned. And if you look at that CLL17 study, the Ven/Obin arm in that study, this was the one that was presented at ASH, the Ven/Obin option had the best likelihood of getting patients into MRD negativity. Mm-hmm. So it was getting people into deeper remissions, had the best CR rate, but there were more infectious deaths in Ven/Obin compared to the pill-pill arm or single agent ibrutinib. And so when you look at the 3-year overall survival, numerically, it was actually a little bit worse for Ven/Obin. So I'm probably going to limit Ven/Obin to my younger, healthier patients and try to avoid it in my older, more frail patients.
So let's talk about ASH. You're an expert on CLL and lymphoma. What were the things that were most exciting for you at this meeting?
Right. So the CLL17 study that I just mentioned, this was at the plenary session at ASH. This was a big randomized clinical trial that compared 3 different arms, single agent ibrutinib given until intolerance or progression versus Ven/Obin given for a year, the way it normally is, versus ibrutinib venetoclax. So a pill-pill combo given for 15 cycles. Now in the US, we would never give ibrutinib venetoclax, but you can give acalabrutinib venetoclax. So I think you can take these results and just extrapolate them to the options we have here. Anyway, the bottom line from this study, the 3-year progression-free survival was the same for all 3 arms. So it provides a lot of comfort in recommending these time-limited options for patients. And again, I think the only patients I'm going to recommend indefinite BTK inhibitors to going forward are going to be the 17p deleted or p53 mutated people and the elderly frail people where just simplicity is just what you're looking for.
Any other studies that were presented that, again, were practice defining?
I think that was the only one that was practice influencing.
Yeah.
There was a study in the late breaker looking at pirtobrutinib, which is a next generation BTK inhibitor against BR, bendamustine rituximab. And like every other trial that was designed like this, the BTK inhibitor was better than immunochemotherapy. But I personally wouldn't leapfrog pirtobrutinib ahead of the current BTK inhibitors until it gives us a reason to do that. And there are trials where pirtobrutinib is getting compared head-to-head against other BTK inhibitors, so we have to wait for those to mature. There was pirtobrutinib against ibrutinib. Pirtobrutinib's looking a little better, no surprise there, but pirtobrutinib would need to beat acalabrutinib or zanubrutinib in my mind for it to jump ahead of it. And then the last thing I'll mention from ASH was there's a new class of drug called BTK degraders. So these are drugs that bind to the BTK enzyme and they don't inhibit it the way the BTK inhibitors do. They actually target the enzyme for proteasomal degradation. So it's a whole new way of trying to deplete the CLL cells of the BTK enzyme. And there's a couple of these in development and they look really promising. So I think we're going to have a whole new class of BTK targeted agents in the near future in our toolbox. So kind of an embarrassment of riches. We have such good treatments for CLL, and I think we're going to have some more really good treatments in the near future.
Yeah, I have to say, as you were talking about the degraders, which again, we've seen in other parts of oncology, including breast cancer, but I was sort of shaking my head with a smile saying, wow, how lucky we are to have all this. Any other emerging therapies that you're excited about?
I guess there is a little bit of data for CAR T-cell therapy in CLL. The CAR T data doesn't look quite as wonderful in CLL as it looks in diffuse large B-cell lymphoma and follicular lymphoma, but it is an option. And we are starting to see these patients who are refractory to BTK inhibitors and refractory to BCL2 inhibitors. So you can still run out of options for your CLL patients, and to have Lysocell, which is now FDA approved for CLL, is a nice thing to have in the armamentarium.
Got it. Let me ask your experience in terms of patients' quality of life. Again, especially in this era of newer targeted therapies, what are the toxicities they talk to you about? How successful are we in terms of managing toxicities?
Yeah, fortunately, the medicines we have now for CLL are generally very well tolerated. Back in the days of ibrutinib, I would have a lot of patients coming in with various toxicities that were problematic, but it's much less with acalabrutinib and zanubrutinib and pirtobrutinib. With acalabrutinib, you need to be aware of the headache risk, and that's usually well managed with caffeine. I've had a couple of patients where we had to switch off acal because we couldn't get the headaches under control. Zanubrutinib, also well tolerated, does have some risk for hypertension, more than acalabrutinib. So I've had a few patients get problematic hypertension on zanubrutinib. And I don't like the idea of chasing a toxicity that I created with more pills. So if I get somebody on zanubrutinib with hypertension, that's a problem. I'm just switching them to acalabrutinib, which almost never causes the hypertension. Easy bruising is very common with these drugs. Almost everybody gets it. So you just have to warn them. It's usually more of a cosmetic problem than a severe medical problem, but they do come in and they just have a lot of bruising because of the antiplatelet effects of the BTK inhibitors. Venetoclax, usually well tolerated, sometimes a little bit of GI upset a couple hours after they take their 400 milligrams. Sometimes people get some cytopenias from venetoclax. There's a little bit of myelosuppression, so you might have to dose modify from 400 to 200 if that patient is experiencing that, but generally well tolerated. And then the obinutuzumab usually is well tolerated. Of course, these people can have very significant infusion reactions to their very first obinutuzumab dose, so you have to be aware of that possibility. And then the infection risk with obinutuzumab is another thing. It's very potent at depleting CD20. I try to get my patients vaccinated up before we start their obinutuzumab because it's hard for them to respond to vaccines post-obinutuzumab.
Prophylaxis, your patients with CLL, I'll say it in general on treatment. Let's say it's a 2 or 3 drug regimen like we've been discussing. So what bacterial viral prophylaxis do you use?
I generally don't have them on any kind of bacterial prophylaxis. If they are getting recurrent infections, I'll definitely monitor the immunoglobulin levels, and some patients will need IVIG replacement therapy. So you have to be aware of that. And that's usually quite effective, actually. They usually don't need antifungal prophylaxis. I will often put them on acyclovir just to try to prevent zoster. So it's usually just Valtrex or acyclovir for prophylaxis. Now, if they've already been vaccinated with the shingles vaccine, does the antiviral add to that? Not sure. So then I have a conversation with the patient. I have had more than a few patients get bad zoster outbreaks, CLL patients who were vaccinated. So the vaccine is not 100% foolproof, and I've had some bad shingles in my CLL population. So I'll still encourage them to take acyclovir or Valtrex, even if they've had the shingles vaccine.
And just a final question. It's not infrequent that a patient says, oh, yeah, I had AFib and it was treated and resolved, or I have AFib. And what do you do about the BTKs in that setting if you're thinking about them or want to use them?
Yeah, the good news is that the AFib risk with acalabrutinib and zanubrutinib is much less than it was with ibrutinib. So this is much less of a problem than it used to be. But it can still happen. And the tricky part, quite honestly, because, AFib can be managed. You can rate control. The problem is they have to go on anticoagulation. And then the BTK inhibitor has this antiplatelet property. So the bleeding is what I worry about. We'll try to manage their AFib while they're on their zanubrutinib or acalabrutinib. But if the bleeding starts to become too much of a problem, I might try to switch them to a different class, like a BCL2 inhibitor, so that they don't have to be on a DOAC and a BTK inhibitor at the same time.
Got it. Very good. Absolutely wonderful. So again, this is Dr. Ken Miller, and this has been another podcast, Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I have to say, it's been a real pleasure and so interesting talking with Dr. Brad Call, who's a professor of medicine at Washington University School of Medicine and director of the lymphoma program. Brad, thanks for being with us.
Thanks for having me, Ken. I really enjoyed it.
And I want to thank all of you for listening to this terrific episode, which I have to say, I think CLL is such an interesting disease, and it's been such a privilege taking care of patients with CLL for so many years, and I've learned a lot today to hopefully even do that better. For all of you, if you would like a listing of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet and recorded webinars on CLL, please visit bloodcancerunited.org/CE. And for any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center at 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, and available resources, including financial assistance through the CLL Copay Assistance Fund. Blood Cancer United also provides other resources for patients, survivors, and their families that can be found at bloodcancerunited.org/support. Finally, I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.